Dr. Jen Wagner, how are you today?
I'm great, David. So good to see you.
It's always good to see you. Did you run this morning?
I did a HIIT class this morning.
Oh, how was that?
It was awesome, as always. 100 burpees. So it's a good
Ah!
way to start the day. Great little body weight work, some plyo work, a little bit of sprints and some weights in between.
After my conversation with Stacy Sims a couple weeks ago, I started incorporating sprint training, which I just have to say is like one of the most unpleasant things you can do to yourself.
It is, but it's so
Oh,
short. Like,
yeah,
I
it
kind
is.
of love it on days where I'm like, I got 20 minutes, boom.
Oh, yeah.
Sun
That's
Peak Hill, do it 4 times.
I do it on a calibrated spin bike. And so
Okay,
what I try and do is I keep it over 500 watts for 30 seconds.
that's
But I
good.
can, well, I don't succeed. This is try. I usually make it to about second 25 and the whole unit just falls apart. But you're right. You do 4 rounds of that and then that's it.
Yeah, yeah, it's fantastic.
Thank you, Stacy.
Yeah, man, she's a beast. I love her.
She's amazing. I wrote her a note afterwards and I said that the sort of asymmetry of her training protocols, which if you don't listen to it, she's like, yeah, you can do that zone two stuff, sort of walk in the park. It's good for your soul, but it's really all about short, either super heavy or super fast.
Yeah,
And how it reminds me of Nassim Taleb and his ideas of Black Swan and anti-fragile. Like, how do
yeah,
you become anti-fragile? This highly asymmetric
yeah.
sort of way of living. And
I
anyway,
love the way she describes it as being like polarized, which I think it
yeah,
helps a lot of people. Like you're
no,
either really on or you're off. You don't spend
yeah.
time in this middle.
No. And she said, if you're off, like if you feel it's an off day, it's just an off day. That's it. Don't
Yeah.
do anything. Anyway, what we're going to talk about today, you're a clinician, you're a
Hmm.
physician, you're not an OBGYN, but you
No.
are a member of the Menopause Society.
Yes.
And there's a big conference in Chicago recently, which I think was of the Menopause Society.
Hmm. Hmm.
And a lot of interesting thoughts there. Something Stacy brought up was the idea of menopause hormone therapy for people who are symptomatic
Hmm.
versus what is known as HRT, hormone replacement therapy. And she makes a difference there. And I wanted to get your thoughts as a physician and a member of the Menopause Society to help us sort of unpack where the thinking on this is going. Because what's interesting, the stat that flew out for me from that conference was that in 2007, 4.6% of women in America were using hormone replacement therapy. In 2023, 1.8% of women are using hormone replacement therapy. So the usage of this has gone down quite a bit, while at the same time, the data that I'm seeing would seem to see there's a lot of preventative upsides to doing something like HRT. But again, I'm not a physician, I'm of the wrong gender, and I'm here to be educated on this.
Oh my gosh. I think it's exciting that we're talking about this. And, I think it is something that even being a woman wasn't really on my radar until it started to affect me. And then you're like, huh, what's going on? And then you kind of start to dive into this. And I am grateful for Stacy and the work that she's doing, for Mary Claire Haver and the work that she's doing, and Vonda Wright. And they're all of these women from, some are physicians, some are clinicians in other capacities who have really taken it upon themselves to say, we need to educate the public about menopause, about hormones, and the different strategies that women can use to feel better. Because I think it's been universal that as you go through perimenopause, you feel most women, I think it's something like over 90% of women have some sort of symptomatology. And even just recognizing that some of that is menopause is a step forward, from going from the classic like vasomotor symptoms. So those are your hot flashes, your night sweats, which everyone kind of equates to menopause, to maybe more vague symptoms like you're not sleeping as well, you're having more urinary tract infections, maybe intercourse is painful, like some things that are changing, mood might be changing, brain fog, all of these things, even to things like gallbladder disease and heart palpitations and tinnitus in your ears and other musculoskeletal things going on. So I think that women have suffered in silence for a really long time. And, it used to be prior to 2002, which is when the Women's Health Initiative came out, hormones were pretty frequently prescribed. People felt bad. They went in, they got some hormones, they felt better. Life went on. And I think, in 2002, the Women's Health Initiative, which a lot of good things came out of, But there were some misconclusions drawn from that data. And the media got a hold of those misconclusions. And all of a sudden it was hormones cause breast cancer. And I think some crazy stat, and I'm probably going to get this a little bit wrong, like 80% of women who were taking hormones just threw them away.
Yeah.
And we haven't recovered from that. And it's 22 years later. And we're just starting to see a resurgence, and we're just starting to talk about it. And we're just starting to see, I think the Menopause Society, which used to be the North American Menopause Society, and shortened it down a little bit, has just released their position papers in the last 2 years. So, we're still playing catch up.
What are those position papers?
So it basically is kind of going back through and saying, this is where we as a society say hormones are definitely indicated. This is where they may be indicated. This is what the FDA is saying. It's just kind of a recalibration of the data and kind of a beginning of a framework for clinicians to put their heads around to say, how do we talk about this? How do we stratify? How do we approach patients and answer questions?
So it seems to me there's sort of a couple parts to this. There's symptom alleviation, and then there's long-term health.
Yes.
Which they seem to be sort of two different things.
Yes.
And two different reasons why one would prescribe. You mentioned some of the symptom alleviation that can happen. What are the long-term health consequences of, and I'm going to use HRT, hormone replacement therapy, and not using it?
Yeah. So I think, the one that probably is most apparent to people is bone density. Women lose about a fifth, can lose up to a fifth of their bone density in the first 2 to 3 years following menopause. And that's shocking and striking, especially if we're talking about women living 1,600 days longer than men. Like, that's a significant increase in lifespan with possible risk of fall and fracture, which we know has a ridiculously high morbidity once it happens. So I think the ability to maintain that bone density is critical. And that is probably where we're seeing the best current evidence of continuing on menopause hormone therapy longer than just pure symptom treatment. Because we know when you stop it, your bone density will drop dramatically. What's interesting with that, they don't necessarily see an increased fracture rate with that, but we know it's happening, which can obviously lead to increased fractures down the way. We don't have a lot of great data because we looked at the data for the Women's Health Initiative. That study population was much older because the design of that study was to look at cardiovascular outcomes. And so they needed to study the women in the age ranges in which they would be more likely to have cardiovascular events, which was kind of 60 to 70. And so we don't really have a lot of great data right now. More studies are being done about what happens when we put women who are 45 to 55 on these hormones and keep them on them. So we're just starting to learn a lot about that. But we know when we stop them, bone density goes down. So if you're a female at great risk of osteoporosis, maybe that benefit for you of staying on hormones long-term outweighs some of the risks that can develop later on. It becomes a very personal and individualized scenario that women just have to be able to work with their healthcare providers, which is a big problem because there's not many of them that are very good at this and have a lot of knowledge in this space.
One of the other stats I saw at that conference is 70% of women have musculoskeletal issues due to menopause. You mentioned skeletal, but also muscular, because I recall one of our previous conversations, estrogen is an anabolic.
Yes.
Which helps you build muscle.
Yeah, absolutely. And so obviously for bone and for muscle and for some of the other things that we'll talk about, this is using menopause hormone therapy systemically. So this is giving estrogen and, if you have a uterus, progesterone in a way that enters your bloodstream versus, we can talk about using vaginal estrogen for a more localized thing, and that can be used in certain populations. But using systemic menopause hormone therapy definitely can improve your lean muscle mass because estrogen is our main anabolic steroid as a woman, as a female. And so there are other ways to facilitate getting some of that muscular stimulation. And I know you just had Stacy Sims on, who's the world leading expert in that. But for some women, that may not be an option, and for some women, that may not be a realistic pathway and lifestyle for, Stacy works with a group of women, and a lot of her advice is designed around these very athletically conscious women. And she's the first to say that, this is my population. And so there is a larger group of women where maybe that is just they're not as familiar with that. They don't have access to that. That's not part of their lifestyle. And so hormones can be very helpful in preserving lean muscle mass, allowing women to continue to build lean muscle mass. Now, to build, you have to do the work. You need to get in the gym, you need to lift the weights, you need to put the time in. But with that, and if women are willing to do that with some help from estrogen so they can actually make those changes a little faster and maybe at a less intense level than what's required without the hormones, it also helps them metabolically. It improves their insulin resistance. It improves their utilization of glucose and all of those things that we lose when we lose our estrogen.
And from what I've read, Dr. Lisa Mosconi talks a lot about brains and estrogen.
Yeah.
So that would seem to be another reason for long-term hormone replacement therapy would be brain health. I mean, my recollection is that women suffer diseases of the brain like Alzheimer's, something, I don't know, 2-to-1.
Yeah.
I make that up, but it's a big number, whatever.
It is. And, again, I think this is where the data is really hard to tease out, because when they looked at some of these sub measurements from the WHI, they said, oh, they have an increased risk of dementia on hormones. Well, that was women starting hormones well past the age we start them. And so it was hard to tease out whether it was the hormones related to this or other factors. I think we are seeing, when women are starting menopause hormone therapy in the time frame where they are symptomatic, that we are seeing beneficial protection and cognition. Again, they're not saying, the FDA is not saying that that's a reason women should be put on hormone therapy or stay on them, but it could definitely be a benefit. I come from watching my mother just recently pass away from dementia. And so it's key on my mind. And I also think, as we are encouraging women to be active in this phase of life, to maintain bone density, to maintain lean muscle mass, then we have the risk of having more injuries. It's like if we're biking and we crash our bike and hit our head, we also know that estrogen and progesterone are very protective, neuroprotective. And so if we are having a TBI of some sort or a concussion event, it's important to have these hormones around. That's another kind of secondary benefit, is if we're on hormones to feel better, to maintain our bone mass, we can heal better. And we probably do have some preservation of cognitive effects. There are studies showing that evidence of brain fog is lessened because we're not losing estrogen's impact on our hippocampus and our ability to remember. We're not losing estrogen's impact on our prefrontal cortex, and our executive function stays, as we perceive it, sharper than when we start to lose estrogen in those regions.
So let's talk about the contraindications. Why would someone not do this?
True medical contraindications are very few. If you have an estrogen receptor positive cancer, that has to be a really detailed and specific conversation with your healthcare team and your oncologist. Outside of that, and some very unique endocrinologic diseases and states, there's very few true contraindications to using this. So I think the biggest obstacle, for women being more proactive in this space is fear. I think there's a lot of fear from what was put out in the media as one thing, and then never really recanted as aggressively as it was expressed. Like we love catastrophe. And so that's what headlines are. And when the catastrophe isn't really real, nobody really talks about that. They're just like, oh, it'll just go away. It doesn't create that splash that, oh, maybe this was a wrong interpretation of this risk. And we have been denying women really useful care for a long time, and intervention.
I had an OBGYN on a while back, so Susanna Gilbert-Lenz, who's a doctor practicing in Los Angeles. And we had a discussion about HRT and cancer, specifically breast cancer, and about how if one is diagnosed with breast cancer, very often, not only is HRT not indicated, but there are other drugs applied to remove all the estrogen. But this causes a whole slew of other consequences. And she had been diagnosed with breast cancer maybe 5 years earlier. And I asked her, so what are your thoughts on this? And she cautiously said it's being reevaluated.
Yeah, I think that's true. I think, the studies are saying that the vaginally supplied estrogen that gets very little to almost zero systemic uptake can be very helpful for some women who are having genital urinary symptoms, which I think we as a culture have decided, why would you even treat that? It's not that big of a deal. I think if you're a woman that's getting a UTI and getting sick all the time and are getting septic from that, it's a very big deal. I think we have all learning more and more about the importance of sexual health, and that is a very big deal for people. There are good proven health benefits to having a enjoyable and productive sex life. And so I think that there are preparations that they have found to be safer in women that have had breast cancer. I also think some of the selective estrogen receptor modulators, the SERMs, are a drug class that's being more and more investigated. So they block estrogen at certain receptors, like tamoxifen is one of those drugs often used in the breast cancer population, but they allow estrogen at other receptor types. So drugs like that, I think, can be helpful for women. And so there's a lot we can talk about this. I think the medical education around this is 100% lacking. And I don't think anyone would argue with that. And I think that it has been siloed so much that people say, healthcare providers, like I myself, I'm an anesthesiologist, right? I'm not an OBGYN, I'm not an endocrinologist. And so for years I was like, this isn't my work. Like, why should I'm not qualified to talk about this. But the problem is nobody was qualified to talk about this. And you talk to most OBGYNs and they get maybe 6 hours of menopause training in a 4 to 5 year residency. We rely on that 6 hours to treat a population, and most of them just can't do it. So I think that, I think there are people in this field who are really trying to make a difference. I think the Menopause Society is trying to make a difference by offering education and certification, regardless of how you're classically trained, because it probably doesn't matter. There are orthopedic surgeons who are trained as menopause doctors now. It's an opportunity for family practitioners and internal medicine doctors, and anyone that takes care of a woman should be able to have at least a basal level conversation about this and should be asking, because I think a lot of things that we see a specialist for can be tied back to menopause, and we should be able to have an introductory conversation about your shoulder's frozen as a physical you go see your PT, or you have a frozen shoulder. Maybe there's actually nothing really wrong with your shoulder. Maybe it's menopause. I think Mary Claire Haber she happens to be an OBGYN. She's really taken this upon herself to create curriculums for other physicians and other types of care providers to say, let's educate each other about menopause. She had to do it herself as an OBGYN. And so I think as clinicians and practitioners, we have to get out of the silo that we think we're in. And if we can provide some information and education to our patients and have a discussion and help them get the help they need, that's step one.
I'm glad you brought that up. I've had Dr. Vonda Wright on this podcast a few times, and she's an orthopedist.
Correct.
Who, as a consequence of her work, orthopedist work with bones, has educated herself on estrogen and menopause because, as you point out, this is not a singular, if you break your arm, okay, that's not systemic. It's just your arm. But what we're talking about here affects everything, all of your organ systems, everything. And so really everyone needs to understand this.
Yeah, I think it is going to take a movement of clinicians and practitioners who are interested in this to self-educate, because if we wait for the medical education system to catch up, we're never going to get there. And so I think it is finding these alternative pathways to education and some certification, and using some very vetted institutions to help clinicians get there and understand, and then also creating and compiling lists. To go back to the Menopause Society again, they're a great resource because they have a list of clinicians that they have certified, because it's really hard to find a menopause certified practitioner. And luckily this is something that telehealth can provide. You don't need to be in the same town or the same city as your health practitioner to talk about a lot of these things. This is something that can be done pretty easily over telehealth. And so hopefully more people can start to access these. And, there's a few commercial telehealth companies that are coming online that are actually providing really great services.
I'm a little bit familiar with that. There's this intersection of, as you said, very little education on this and its huge impact. And the OBGYNs are just overwhelmed with, this is going to sound bad, but making babies.
100%.
That's their thing, right? They don't have really the brain space to take this on. So that some of these telehealth companies have come in. It seems like they're fulfilling a need.
Absolutely. And I also think, I've had 2 children, and you see your OB and you have a lot of high touch points around that time. I don't think I've gone to an OBGYN in years. My primary care has kind of taken over that that side of my healthcare. And, you know, you and I have talked about this before. The idea of women's health is so much broader than just reproductive health. You know, just what you just mentioned, that we have estrogen receptors on almost every cell in our bodies. And so it's not going to fit under one silo. And so thank God there are the von der Wrights who are saying, wow, you're coming into my clinic. I can see your bones have a problem. Let's talk about this. This is a
Yeah.
systemic issue, right? This is not your arm or your knee or your tibia. Like, this is a systemic issue. You know, I even think about some of the people that I could have touched in the operating room if I would have had more education about this when I was still in that clinical practice, to say, gosh, you're complaining of all these vague symptoms. Like, have you talked to your healthcare provider that this might be going on? Even just to teach them to ask the question, because I do think sometimes you don't connect the dots as the patient. And our healthcare system is so specialized that as a provider, sometimes you don't connect the dots. Oh, you're coming in with palpitations. It would be interesting to do a poll. How many cardiologists would equate palpitations with menopause?
Right.
I'm guessing not very many. You know, I think that takes an awareness and being taught that, or it's really low down on the list. And of course, they have to rule out serious things. I'm not saying that everybody should just equate everything to menopause. When you start to piece all of these symptoms together, there can be some uniting things, which I think then hormones can really be helpful for.
I know we say at the beginning of this podcast, but I just want to be clear here. I'm not a clinician, and Jen is not giving medical advice here. We're just having sort of a discussion of what the landscape of this is.
Yeah.
The other sort of interesting thing I hear about this, which you don't hear with a lot of other parts of medicine, is that this is a natural phase. This is a natural thing. And this is somehow good. And I just think, well, so is entropy is, but that's not necessarily so good. Again, I don't really have a dog in this fight, but what are your thoughts on this?
This is probably going to be an unpopular statement, but I think, you know, if this happened to the other half of the population where their sex hormones precipitously decline to almost nothing and they're very symptomatic through it, something would probably be done. And it is, I heard this the other day. I was listening to someone talk about this and they're like, well, men can go down the street to Circle K and get testosterone, you know? It's like, it's become this huge thing for women to get on menopause hormone therapy. And we've played around with language a little bit. And I think that societies and the practitioners are going in and starting to use that menopause hormone therapy language, because we can't replace what's lost. It's not a replacement. It is a treatment designed to help with long-term things like bone health, long-term things like cardiovascular disease, long-term things like cognitive health, and shorter-term symptoms like vasomotor symptoms and things that sometimes get better. We're getting better about when we start these things. We're not as good about when we end those things. And again, I think that becomes a very specific conversation that is very personal to the individual patient and their provider, based on a lot of risk stratification and symptomatology about when do you stop and how do you stop. But yeah, I think the conversation would be very different if this was happening to the other half of the population. And when our life expectancy is double what it used to be, I think we have to really think about how women are feeling in these other decades. You know, if we want women in the workforce in their 60s and 70s, they need to feel good. They need to be healthy. Their bones need to be strong. They need to be metabolically healthy and cognitively healthy and all of the things that hormones can help protect against. And so, yes, it is a natural phase of life, but it's not one that people need to suffer through. One is like, there's no badge of honor in that. And that can have really deleterious side effects that, you know, if you go through another 6 or 7 years without sleeping well because you're drenching your bed every night, that's not good for your health either.
No, as you were speaking about this, I take an 81 milligrams of aspirin every night. I take a baby aspirin every night, which is also not natural, but there's a lot of evidence that this is positive for my cardiovascular system, and it has some, anti-cancer effects. And so, okay, I don't get any pushback about that in the way that this topic, I know it's interesting.
It's shocking. It is, it's just,
Right.
yeah. And it's become, I think part of that is because it was so taboo to talk about it. And I think some of that is protective. Like, I was at a party this weekend with my husband, a retirement party for one of his colleagues. And I had a woman come up to me and she's like, I really would like to talk to you. I'm like, absolutely. And my husband happens to be her boss. And she goes, do you know how embarrassing it is to sit there and be in a room talking to him and I'm turning bright red and I'm sweating and I can't
Oh my
concentrate on what
gosh.
he's
Right.
saying because I'm
Right.
having all these symptoms and I'm just hoping he doesn't notice. And
Oh my
I
gosh.
was like, that's awful.
Right.
And that's a one-on-one conversation with what I would hope is a very understanding individual, given what I do for a living. I hope he's understanding when this is happening to other women. Can you imagine being on stage or in front of your boardroom or in the
No.
courtroom or, taking care of a patient as a practitioner and that's happening to you and you are so uncomfortable and you're so distracted? It's horrible.
My good friend Tamsin Vidal, because she was a newscaster, and this
Yeah.
happened to her on camera, first time. Oh my God.
Yeah.
Yeah.
So,
Uh, so I think one of the important things here is both of us have a certain allergy to what we'll call prescriptive protocols, especially from people that don't have a lot of responsibility with declaring these prescriptive protocols.
yeah.
This all seems extremely personalized, and I've heard, Dr. Peter Attia talk about certain estrogen levels in luteal phase and measuring these things. Some other people feel it's really not about that. It's just really symptom driven. At what point would you say that someone, I think Attia is talking about perimenopause or pre-perimenopause, like fairly early on. What are your thoughts on that?
So most of the studies that I'm reading, it is symptom treatment. Because if you're having if you're symptomatic, doesn't matter what your estrogen level is. Because again, we're all different. And we all make, our variations of estrogen and how sensitive our receptors are.
Hmm.
Every human is different. And so I don't think you can say that, oh, just because your estrogen level's here, we're not going to treat you if you're having these symptoms. If you're having these symptoms, those estrogen levels have fallen enough in your hypothalamus that you are no longer regulating your body temperature correctly. Like that's a central nervous system response. And so most menopause practitioners that I follow and I have read don't worry about measuring hormones, which I think frustrates a lot of people because they want that data point. And I again, if you're asymptomatic, maybe it's helpful, but then a lot of asymptomatic women are choosing, maybe they don't need something as aggressive as menopause hormone therapy because they're not having the same symptoms. I think all women at this stage of life should have a DEXA scan so they know their bone density starting, and that should be monitored yearly. And so these kind of silent things that start happening, like maybe you'll never have a hot flash. Maybe you'll never have a UTI or some of these other more noticeable manifestations of perimenopause. But that doesn't mean your bones aren't declining. We know it's going to happen. That doesn't mean some of these other things aren't preventing, it's same thing with cholesterol, right? We see women's cholesterol start to rise as they start to lose estrogen's effects on their biliary systems, on their gut absorption, on their blood vessel and the intima of their blood vessels. And so we see changes in cholesterol profiles. And some people, that's how they monitor the effects of their menopause hormone therapies. Like, are we
Hmm.
on the right doses? Well, what's happening to your cholesterol? What's happening to your bone density? Because checking these levels, and we also have to remember that checking hormone levels is really complicated, especially in perimenopause when your cycles are irregular. You don't know what day you're on, and those levels are changing all the time, which is also the difference, which is why we've gone away from hormone replacement therapy. Hormones are pulsatile chemical releases within our body. When we're put on menopause hormone therapy, it's not replacing that pulsatile nature of those hormones. It's not in the same phases, et cetera. It's not like our body pulses out the same amount all the time. It's very varied based on this complex signaling. And so that's why menopause hormone therapy is like, okay, we're not replacing what was there naturally. We can't do that. But this is, the therapy to treat these conditions.
I'm curious about the dosing here and how are there counter symptoms that come up if the dosing is too high? How do you know?
So I think, again, it really becomes on symptom management. And most of what I've read in this is you start with kind of the lowest dose that you can. I don't think I have met a person where right off the bat, the patient and the provider got it right. It is an adjustment. Again, it's very individualized. Like, do you need progesterone or do you not? And that depends if you have a uterus. What form of estrogen do you want? Do you want a pill? Do you want a patch? Do you want a cream? Do you want a gel? So I think it goes back to working with a provider to say, maybe I tried oral and I had GI side effects.
Hmm.
And was that the dose? Was that the route? difficult to say. So I think there's so much personal variation in this that I can't say, oh, you just start here, because there's so many different formulations, there's so many different routes that it really does have to be a very personalized discussion. I think, again, starting low and going up, and then most of the side effects that I've read, I've had a friend that instead of getting fewer UTIs when she was on systemic estrogen, ended up getting more. She was like, this doesn't seem to be working. And so had to kind of go back in and recalibrate what she was taking, how she was taking different preparations. So again, it's a super personalized thing where it's definitely not one size fits all.
So you mentioned two hormones, estrogen or variants thereof,
Mm-hmm.
and progesterone.
Mm-hmm.
Is testosterone part of this?
So for some people, yeah. So, I think testosterone is probably the one thing that could be measured and is probably helpful to measure. So the idea is to keep testosterone levels in what is considered physiologically normal for a woman, which the labs will say kind of under 70. Some providers will push that higher, more to like 100, 120 without getting side effects of testosterone, which can be facial hair, can be some other even permanent side effects from having too much testosterone. So I think, testosterone can definitely help with libido, can definitely, assist a little bit in the muscle mass. It's not the way that estrogen is going to in a woman, but definitely is a positive effect there. It's just not the same as it is in male physiology. And so I think that that is one thing that sometimes providers, a level they do look at. And if there are still some side effects or having some of these lower libido and other symptoms, can add it in. And that can be done in a little more targeted fashion because you can actually target levels there.
So all of this is leading me to the question of finding the right practitioner to work with. And my wife went to see an OBGYN, and when she came back, I was like, how'd it go? And she told me some stuff. I was like, fire that person.
Yeah.
I'm not an expert in this field, but I know enough that like this was not somebody who's going to give you good advice.
Yeah.
Would you say going to that list in the Menopause Society of certified practitioners, how do you find somebody who really knows how to deal with this?
Absolutely. I think that's a great place to start because those are providers, regardless of their formal training, have gone back in and have done the work to understand this. They've read what's recent because they have to pass a test. And so they've had to really dive into what it means to go through menopause, what the risk factors are, what the therapies can be, both pharmacologically, supplements, lifestyle, all of those things. And so I think that's a great place to start. We talked about some of those commercial telehealth companies, Midi's one, totally blanking on the name of the other one right now. I think those are interesting resources to look at. I know there's one that takes insurance, one does not. So I think those are interesting places. I think if you have a good relationship with your general practitioner, that's always a great place to start, to say, I'm really interested in learning more. Is this something you can help me with? Is this a journey you want to go on with me? Or can you refer me to someone? I know I'm in Utah. They just started a perimenopause clinic at the University of Utah. And so there are places like that popping up. Unfortunately, it still takes a lot of legwork on the patient. And I think the hard part is if you have patients that are motivated, that's great. But when you have patients who maybe have not had a lot of access to healthcare and don't even understand that perimenopause is causing the symptomatology, they don't know what questions to ask. And so I think that that is where putting a little bit of pressure on clinicians to say, every clinician needs some basic education around this. And, it's interesting, like every clinician got some basic education around COVID, right? Like, I mean, that's like a perfect example, right? And menopause is something that is going to, if you have female physiology, you will go through menopause. Like you said, it is a natural stage of life. That doesn't mean it has to be an uncomfortable and detrimental stage of life by any means, but it's natural. And so, like every clinician, I would even say physical therapists, chiropractors, like everyone should get some really good vetted training and education on this because we all interact with women who have different access to healthcare. And those are the populations I worry about the most, who really do have poor access to healthcare. And maybe they are seeing other types of providers. And so just making sure that there is good vetted information out there so people can educate themselves.
I also want to bring up something that you mentioned about we all just yearn for the blue pill that's going to solve everything. It's just a natural human state.
Mm-hmm.
But there's other sort of complicating other adjunct things that are going on here. So your diet, your weight, your activity level, all of these things, you're a human with systems.
Mm-hmm.
And these all have inputs in the system. I mean, it's like some men think, oh, if they do TRT, testosterone replacement therapy, and they don't do anything else, everything's going to be hunky-dory. No, you have to take a lot of other actions to actually make use of that hormone. It's the same here. So obesity would not be I'm not going to say it's a comorbidity, but it's a cofactor here.
100%. And we know that women who are obese have more symptoms going through menopause. They have a tougher time. Absolutely. Again, going back to the work that Stacey's doing, that Dr. Stacey Sims is doing, which is amazing work to say that, I have this really active population, and we have found in this population that has the mindset and the ability and the want to push themselves physically, we can overcome some of this lack of estrogen. Like there are other pathways. And so for some people, that's the right place to go. There are adaptogens that can help, which are plant-based supplements that for some women, especially women who are having really mild symptoms, some of those have enough estrogenic effects that they're seeing decreases in their symptomatology. And that's a comfortable route for them. For other women, menopause hormone therapy has been a very advantageous route to go with all of the benefits that we've talked about with very little risk in the overall population, and I think so there are definitely ways, but absolutely, if you can optimize your lifestyle factors, if you are sleeping well, which sometimes you need these things to sleep well through perimenopause and after menopause, if you are eating well and eating like we've talked about so many times, whole foods, nutritious foods, not eating processed foods, all of those things help. And then I think as we come back to almost every time, movement is probably the best thing. Like we were talking about right before we started, adding in this, what is becoming more apparent and more well studied, especially for women in this stage of life, is this idea. And again, Stacey's done all the pioneering work here with this idea of polarized training, of being really intense or recovering and not spending time in that gray area, because that's really what changes the neural signals that are coming out of the brain to tell the bones, to tell the muscles to build. And then you have to couple that with nutrition. They found that if you create those neuro signals by working really intensely physically, but you don't have the nutrition on board, you're still not going to get the benefit. So you're exactly right. They're all interconnected. And the more we optimize those lifestyle levers, the less symptomatic we are finding women going through menopause, and the probably more impactful the hormone therapy will be.
It brings to mind, we have a mutual friend, Alyssa, who I remember she's been on this podcast a couple of times. She said, well, menopause didn't really happen to me, but she is like a super athlete. I mean, her idea of a good time is like, let's go climb K2.
Right.
That sounds like a lot of fun.
Right.
Okay. Super fit and highly attuned to nutrition. That's N of one. I'm not saying that like everyone, you should not climb K2. Just don't do that. That's like, just take that off the menu.
That's not on my to-do list.
That's not that, like if you have menopause system, climb K2. No, don't do that. There does seem to be some sort of overlap there. It's interesting that, again, I'm not a clinician, I'm not a researcher, but like sort of what I see is this stuff that sort of like Malcolm Gladwell talks about with the tipping point. Like you just sort of keep putting these stresses on your biology and you get like one too many and things just sort of flip into, we're no longer in homeostasis. Bad stuff's happening. So it's a combination of things. And my most recent sort of obsession is microplastics. Their accumulation in the organ system, especially the brains. And I'm sorry, women, they accumulate more in your brains than male brains. All this stuff is always, it's just worse to be a woman. What can I say?
Yeah.
You guys live longer, but you got issues. So, that stuff messing with the endocrine system, which I have got to believe is going to impact everything that we talked about today. That's going to be one of the things. Any other sort of toxins in your life, your lifestyle, and as we talked about, activity and these things, it's really a universal package to look at. And I think that's one of the things that becomes confusing and contradictory. As you said, a lot of people don't spend their days reading this sort of stuff. And what I've learned is that you just sort of nibble at the edges of all this stuff, and it'll be like, oh, well, this only makes like 1% difference or 0.5%. But if you have like 20 of them, all of a sudden it becomes impactful. And I think that with all of our health, I'm not just say women's health, but like everyone, it's really important to keep that in mind. And the other point I really want to stress here is this idea of we are individuals. Prescriptive protocol, if you look at the way any sort of science is done, there will be a distribution of data from which a curve is drawn. And I can absolutely guarantee you, everyone who's listening to this, there will be one of these curves where you're way out on the left or on the right. And all of the suggestions are based on the center. But you really need to speak to someone who's a responsible clinician who can understand all of these bits and how it goes together to deal with whatever symptoms or non-symptoms or whatever your goals are.
Yeah, I can't agree more. And I think that as we develop more and more understanding of the human body and systems and how they interact, when they map the human genome,
Right.
there was all this excitement that we were going to have, our each own very prescriptive plan based on our genes. And that just hasn't happened. But I think what has happened is really the need for more personalized approaches to how we treat patients. And it's hard because that takes time and that takes resources that are just usually not available to most practitioners. And, those that have the ability to do that usually, unfortunately, can only reach a socioeconomic class that can afford to pay for those services at that level of personalization. So it is really hard. And so I think, again, I want to applaud the efforts that are being made to provide really high quality education materials to clinicians, to consumers. And I think it's hard to weed that out through the noise. And menopause is a buzzword right now. And you have everyone jumping on this bandwagon, which is great for raising attention to it, but then challenging as a consumer. Where do you go to get good advice? These are really personalized decisions, and just kind of dabbling in things on your own can be dangerous. And so it is a challenge to find the right person, but even just establishing, and you and I have talked a lot about this, like I'm very fortunate, and my primary care doctor has taken an interest in menopause, and she gets a lot of education in menopause, and I feel very comfortable having these conversations with her. But I've also brought things to her attention from my unique physiology that she doesn't, and she's very willing to say, well, I don't understand this. Let's get you here. Let's get you there. And, I am fortunate that she is an insurance taking kind of pretty normal general practitioner. And so I think it is just, again, learning to advocate for yourself and learning what questions to ask. We all have to be our own advocates, and it's just going to take a while for the healthcare system to catch up, if it ever does in our current system. It's a super big challenge.
Jen, we're going to give you a plug for Prosper.
Thank you.
Tell us what Prosper is. What are you doing?
So Prosper is a company I started about a year ago that is designed as holistic women's performance. And really it is our goal, we talked a lot about the clinician space. It is our goal to bring a lot of this into the business space and into the leadership space, where we're on a mission to kind of redesign what professional development programming looks like. And this is kind of our B2B offering, where we work with organizations and kind of their female leadership in their mid-career to late career female talent. And when I started it, I wasn't expecting to become a menopause expert. That wasn't on my radar. And the need of women in these situations to have this education and the opportunity to explore these areas brought to them has been overwhelming, I would say. And we get in these rooms and it's all they want to talk about. And so we have really dedicated ourselves to go back and educate. One of my partners is deep in the strength and conditioning world, and another partner who well, Lindsay's deep in the mindset world. And so we have really gone back in to say, we need to make sure that we are giving proper lifestyle advice. We don't give a lot of medical advice, but we do try to educate on how do you find a provider that can help you do this. So we spend a lot of time doing that more in the business space and the business world, whether it's with sports, whether it's with healthcare providers, whether it's with corporate executives. And then to try to reach more people, we're launching a podcast tomorrow called It's Time, where Lindsley Donnelly and I really just explore all of these issues that are affecting midlife women. We share a lot of our stories. We're bringing on a lot of great experts, including yourself, to just talk about this stuff and really help midlife women want to look forward to what's in front of them instead of always just feeling depressed that things are changing and et cetera, which is, I think, kind of the cultural ideas around menopause is like, you're not a useful female anymore. You're going into this like later stage of life where you're not supposed to enjoy things, and really trying to reframe that. And in the meantime, giving a lot of strategies to feel as great as we can through those phases.
I look forward to it.
Thank
you. Guys doing great work. It's always a pleasure to have you on. This is a very complicated topic, and you're able to just simplify it and make it easy to understand. And we appreciate that.
Thank you. Well, thank you. It's always a pleasure to chat with you. I can't wait till you're back in town and we can hang out.
Soon. Yeah. Snow's coming.
I know. Well, it was 80 this week, so I'll take.
Well. All
Thanks,
right.
David. Always good to see you.
Take care, Jen. Bye.
Yeah.